Yeah, hi. How are you?
I'm fine, sir. How are you, sir?
All good. Good evening, everyone.
Good evening, Lalit, sir.
Hi, Tirumulesh and Manoj. How are you?
सब ठीक है सर कैसे हैं सर
Just surviving.
But your background says otherwise, sir. You look to be in paradise while we are still at home.
Background to whatever you want, you can do.
तो सर ने अपना पेटेंट कर लिया सर आपका पेटेंट हो गया वो
Yeah. नहीं वो एक्चुअली इसमें ना जब शुरू किया तो वो अपने आप ही आ गया था.
वेरी गुड सर वेरी गुड
It gives a refreshing feeling. That's all.
एब्सोल्युटली
और मनोज कैसा चल रहा है आपका आई डॉक्स?
सब ठीक है सर all your blessings going on well.
नहीं अच्छा काम कर रहे हो आप. How was your recent? I read somewhere that 3D surgery you did on this.
Yeah, it was very nice sir live 3D surgery very nice.
Yeah.
Actually this technology is for vitreoretina sir people are marketing for cataract.
Yeah, I think वो सब करेंगे तभी इनका cost effective होगा. Otherwise, only we are too expensive so much.
Yes.
That everybody, Mohan Rajan and somebody people can afford. Everybody can't afford it.
Sir, you can afford, sir. You are the richest vitreoretina surgeon in India. Correct now, Tirumulesh?
It's true.
Right?
It's true.
Yeah, I agree. My gut feeling is if I was actually between we had that RMG group, I would have definitely kept it. But if you're an RPC, I was Tirumulesh when I was there as a store in charge. I bought the best.
Correct, sir. Totally agree with this.
That's true.
Hi, Apur.
Hello, good evening, sir.
Hi, Apur. Why are you doing a dark room procedure here?
I'm trying to find some good lighting here.
Hi, Apur.
Hello,
How are
sir.
you?
Hello, sir.
Hello, Apur.
Hi, sir. How are you?
Hi, Dr. Pawan. Pawan is. I think he has joined.
Only Dr. Manoj is in N95 mask. He's still working.
I'm at hospital, still working.
Oh. Why do you work so hard till 8 o'clock?
That's a everyday routine, sir.
2nd
8,
October
8:30.
also, sir.
Yeah. I remember हमारा तो routine ही 8 to 8 हो गया था ऐसे ही.
Sir, but you also keep evening OPD तो आपका भी रहता है ना sir? When, sir?
No, actually I finished my last appointment is at 4:30 because उनको निपटाने में 7 बज जाते हैं.
Yeah.
So after that because वो सारा workup, dilatation, angio, OCT सब करने कराने में तो कई बार लेजर कभी इंजेक्शन तो इसलिए लास्ट अपॉइंटमेंट 4:30. हाय पवन.
हेलो सर.
कैसे हो?
बहुत बढ़िया एकदम.
अच्छा. We'll try to start in time and finish in time so that we have ample time for we finish in time.
Correct, sir.
Yes, sir.
Correct.
Don't keep prolonging. Hi Aditya.
Sir, good evening. How are you?
Don't get confused here in afternoon.
नहीं, that's what I was looking at several photos.
Hi, Aditya.
Hi sir जी, कैसे आप?
केम छो मजामा?
बस मजा जो सर. Trying to recover from chikungunya. I had chikungunya 3 weeks ago. And surprisingly, it has affected the midfoot in the right leg. I mean,
only the foot.
Only the foot, sir. I mean, some on extreme movements, I can feel some pain in the thumb. And main is that mid calcaneal. I mean, the calcaneotarsal joint. That is the only one affected. Hello, Dr. Tirumulesh. How are you?
Fine. So you caught chikungunya in Germany or back?
No. Here, Germany, there is no Aedes aegypti mosquito, so no chance of getting. Only in India, actually, sir. Only in India you will see monkeys sitting on top of a Mercedes and stuff. So I think it only happens in India.
No, in India, the monkeys are also divine. So.
Yes. So everything is divine, including one leaf. From trees to humans, everything is.
So how do you feel after coming back from Germany? ना वहाँ पे इतना system है, यहाँ system कुछ नहीं.
सर वही है, मतलब यहाँ पे आपको कुछ explore करना है तो इंडिया में करो. वहाँ पे तो you can't move out of that set pattern that they have. If it is like for example.
The beauty of all this, developed nations, there is some system, there is some accountability.
Absolutely, sir. Sir, and best thing there is, one is patient trust, second is compliance.
Just want to let you all know that we are live already. It's been,
I think there are 3-4 minutes there.
3 minutes.
we have 3 minutes left, but we are already live. Just letting you all know.
We will live after 3 minutes only.
So we are live already. We are,
That's why I'm asking why.
I'll
Too
just
soon.
check with them why we are live already, but
Right.
it's email. Yeah. All right, sir. Tech team, can we like go live after 3 minutes once the session starts? Tech team, come in.
Yes, ma'am.
I don't mind
Can
if
we
it's
go live after once the session starts at 7 sharp?
मैम पे टाइम लगता है 1-2 मिनट.
चलो ठीक है, जो भी रहने दो, कोई बात नहीं, फर्क नहीं.
सर वैसे भी अच्छी बातें चल रही थी उसमें.
Yeah.
Just letting you all know if you want to avoid something, you all
No.
should
I think
No,
everything is quite acceptable on this.
no issue at all.
Sir, actually, that's the whole thing about Germany. You know, everything is regimented, and
Yeah.
you advise here. It is all based on suspicion. There, it is generally trust and compliance. Main thing is that compliance. You know, they are mentally.
That is the biggest learning we have once we come from that place. I wrote a big letter to my boss that अगर आज से हम शुरू करें ना, what they are following, it will take at least 2 years for us to start improving, and it takes
Exactly.
2 decades to come up to that level. ये पक्का है. If you start working like that.
Sir, आप सोचिए मतलब वहाँ पे
clinicians here are very good. सब कुछ. You see, everything is very. Manoj Khatri can demonstrate world-class surgery, but the issue is of system, of accountability and discipline. That's it.
Sir, in AD stoning pupil, you have to issue an ID to the patient so that if he's found lying on the roadside, nobody will mistake him for being brained. ID देना पड़ता है, मतलब ऐसा तो.
Shall I think we'll start in a minute or so?
Yes.
Or so what I'll do is I'll initially introduce the this webinar, and after that we'll go around and have some personal discussions about the clinical real world experiences. And in the beginning only, I think I will request Apoorv to tell us about what is the unmet need, and after that we'll have some discussion and some take-home messages.
Okay, sir.
Now it is in my watch exact 7 p.m.
So it's 7 already. I'd like to introduce Dr. Lalit Verma, who's going to be the chairperson and the moderator of the session. So you can take over.
Thanks a lot, Zubi. Thanks, DOS. I'll start sharing the screen.
Sure.
Just let me know if it is visible. That's it.
Yes, sir, it's visible.
Yes, sir, it's visible.
So there's no video here, so there's no issue.
Yes, sir.
So good evening, everybody. Namaste. Sat Sri Akal, sab kuch. So it's nearly, I think, 2 years. 2019, I remember I was still in San Francisco at that time when Brolucimab got this FDA approval, and I saw the entire city painted with Brolucimab. Even the elevators, lift, har jagah ek hi label laga hota, grow view. And I thought, pata nahi kya ho gaya, itna magic drug aa gaya, and how much money they must have spent. And it's clearly 1 year that most of us have had some experience in India, usage of this drug as a real world scenario. So today, couple of us have gathered here primarily one webinar and one drug we'll discuss only, and focus is only one. What is the real world scenario? We know about Hawk and Harrier, how we got this approval, all these studies, I think we have gone through them. We can still discuss about that, but focus will be primarily on real world usage. But the reason is there have been lots of myths. There have been a lot of disconnect between whatever has been reported and what we have found. So that is the reason we are here to dissect what's the actual thing. A lot of us have had now personal experiences. So for this, I think we have 5-6 speakers with us. Dr. Apoorv, he will tell us about what are the unmet needs in AMD. Because AMD we have known since the time when we used to do, macular photovolume study, sometimes direct laser, even in foveal CNVMs. Then came PDT, then came Macugen, so many anti-VEGFs. So still, we have some unmet needs. I think Apoorv will tell us. We will not speak here now. Then a couple of us, between me, Srinivas, Manoj, Aditya, Dr. Mehti, will tell us our personal experiences. I know Aditya and Dr. Mehti have published, papers on the real-world experience. We would love to hear that also. And then we will be joined by a few panelists, Rajiv, Pawan, and Pawan has already joined, and Chakitan Singh, Anil Mishra, Tirumulesh also is here. So as a formality, I'll just introduce few words about the speakers and panelists, because the slides have been prepared and passed on to me. So I'll just read a couple of lines. Apoorv is a very lovable colleague, very lovable colleague.
Thank you, sir.
And we know he did a residency at Arvind. He was consultant for a pretty long time at Chitrakoot. Chitrakoot is in MP, a very high volume setup. I have been there. They have a huge number of model OTs. And then he had a content at LV Prasad. And he has received in this young age so many, acronyms, FICO, MNS. Very nice, Apoorv, keep it up.
Thank you, sir.
Srinivas will join. Srinivas again has a lot of fuss to his name. He was the first Indian to work for Argus Artificial Retina, and I think he's still interested to bring it to India. He also has received so many awards. The biggest thing which I always envy is Rees Bakla Award 3 times, 3 consecutive years, which I think is a record in itself. Apart from that, there are other achievements which are listed here. Manoj Khatri, again, a prolific surgeon, and he does a lot of live surgeries. For last couple of years, I have seen every conference. Even recently, he did the 3D live surgery a couple of days back, and he is the brain behind this iDocs Eye Hospital. Also, he was a Rajan Eye Care, and excellent surgeon, and a lot of patience once he's doing surgery. I have seen his live surgeries so many times, and he's also part of various drug trials in ophthalmology. Then Aditya, we're just speaking to Aditya, is from Gujarat, master's degree from Ahmedabad, and fellowship at LV Prasad. Also did a short stint with Karl Klaas, again a world-renowned surgeon in Belgium, and he again is a researcher. As I said, I just found out from the net and copied, cut paste from there only. And he authored this paper, which, because I was searching 3-4 papers from real world scenario, and then came across this REBA study, which Aditya will tell us, but this was a 78 eyes, both naive and switch therapy, follow up this much. There was only one patient in this study, at least, who developed vascular occlusion.
Thank you, sir.
Dr. Mehti, again, a prolific VR fellow from the East, and he did his VR from Aditya Jyot, has received various awards, nationally, internationally, a lot of presentations at international forums, especially ASRS, Euratina, VRSA, AIUS, and he loves to train. I know this figure is underwritten, but he must have trained huge number of VR fellows. So this was another study which I found out. In fact, in the last webinar, he had told me that this study is on the way, and this is known as Braille study. Again, you see nearly 100 eyes, 126 injections. The conclusion I have underlined here is notably no intraocular inflammation. Whereas if you see Hawk and Harrier, they say 4.1, incidence of some inflammation or vasculitis there. So what I was saying in the beginning also, there is a disconnect between what we are finding and what is being reported. Hence the role of this webinar, hence the role of this sharing of information. And I want that pan-India, we should have some collective information so that all the myths and realities come forward. Because what do we want? All of us want that unmet needs should be taken care of, and we should offer whatever best is possible. You see, no patient should tell us, sir, वो दवाई आई है तो आपने बताई नहीं उसके बारे में हमें. So because it's a Google world nowadays, so everybody wants the latest information to be told at least. So I hope we'll be joined by Rajiv. Rajiv is a very dear friend in Delhi, and he has his own VR setup, Safe Site Center. He did his graduation course from Maulana Azad, and he is an invited speaker in a lot of these conferences, primarily because very sharp, crystal clear messages which he conveys, and does exclusive VR work in Delhi. Pawan has already joined, prolific surgeon, in fact, one of the chief VR surgeons at I7 group of eye hospitals in Delhi, product of Chandigarh, and had some short stint at Vinu also. A lot of honors to his credit, and does exclusive VR work in Delhi. Chekidan Singh, again, is a consultant eye surgeon and specialist in VR from Rohtak. Hopefully, he will be with us. He is a FRCS also, and ICU examination cleared also. We will listen to him also. Colonel Mishra, again a prolific VR surgeon in Army, and he has a lot of Seva Medal and Vish Sena Medal to his credit. Presently, he is HOD of very renowned R&R hospital in Delhi. Was earlier associated as HOD in Army College of Medical Sciences, and thrice recipient of Presidential Award also. Praveen Jain, associated with the ASG Hospital in Jodhpur, Rajasthan, loves to do sutureless vitrectomy. More than 8,000, I don't know. I think that again must be a record. Also awarded Rest Buckler Award. I had one slide, I don't know where it's gone, about Tribulesh and Gunjan, but Tribulesh is a very dear colleague. He is from RP Center, and again, a very prolific VR person. So with this very brief introduction, I will pass on the mic to Dr. Apoor to tell us
Thank you, sir.
about unmet need. क्या हम कर रहे हैं और क्या बचा है हमें करने के लिए. अपूर्व.
Thank you, sir. I'll share my screen now, sir.
Yeah, please. Hi, Gunjan.
Yeah. My slide, is it visible now?
Yeah.
Am I audible, sir?
Yeah. Please carry on.
Okay. Thank you, sir. Good evening, all. Thanks to DOS and thanks to Team Novartis for the opportunity here. I'll be speaking on unmet needs in the management of neovascular AMD. This is the disclaimer. I'll be speaking under the following broad headings. First, the need for effective therapies in neovascular AMD, the extent of the problem, continuing decline in vision in neovascular AMD in real-world scenario, burden to the healthcare system because of neovascular AMD, burden to the patient, and a summary of the above. I'll start with the need for effective therapies in neovascular AMD. Now, AMD, as we know, is the leading cause of severe and irreversible vision loss worldwide. It affects about 10 to 13% of adults aged over 65 years, and now it's the #1 cause of blindness in developed countries. And the prevalence of neovascular AMD and AMD in general is rising as a result of aging population and rising life expectancy in these countries, developing countries and developed. We had approximately 196 million cases by 2020. And neovascular AMD, although it forms only 10 to 15% of cases in AMD, it accounts for the majority of vision loss in AMD because of its severity. As we discussed, it's already the leading cause of blindness in developed countries, forms about 50% of total blindness in developed countries already, which is equivalent to cataract, glaucoma, diabetic retinopathy, and all other causes combined. And this might be the scenario in the future in India as we proceed towards further development. Over the years, research has focused on providing effective therapies for neovascular AMD, where in the pre-1980s, we did not have any treatment. We started doing thermal laser in the 1980s, which still resulted in retinal scarring and recurrent neovascularization. PDT came up in early 2000s, which slowed the progression of vision loss, However, the majority of patients did not see any improvement, but in fact progressed towards gradual vision loss. 2005 onwards, anti-VEGF agents have revolutionized the treatment in neovascular AMD, where we can not only stop the disease from progression, now we can actually talk about visual improvement in these patients. The advent of anti-VEGF therapy has reduced the incidence of blindness. This is data from Denmark, which shows how the incidence of blindness has nearly halved following the introduction of anti-VEGF therapy in 2006. Now, anti-VEGF monotherapy is established to be the gold standard for neovascular AMD. It has dramatically reduced the incidence of blindness and severe vision loss in neovascular AMD. However, in the real world scenario, we still see that we're not able to achieve the visual outcomes seen in clinical studies. And hence, these unmet medical needs exist for newer treatment options. To summarize, there is a need to build on successes in neovascular AMD care and to continually innovate to prevent blindness caused by the disease. We'll talk about the extent of the problem. Now, the global burden of neovascular AMD is already substantial, and the cases are expected to substantially increase over the next few years. As we can see in Asia and other developing countries, these numbers will rise substantially as with rising populations and rising age expectancy, rising life expectancy in these countries. And this will make the burden of neovascular AMD even greater in the future. This increased prevalence is set against costs that are already high. As you can see from this data, the neovascular AMD patients have significantly high health resource utilization costs as compared with controls. And they already form a significant amount of percentage of health-related expenditure in developed countries. So to summarize, increasing prevalence of the disease along with high resource utilization and high costs will be extremely difficult for healthcare systems to manage in the near future. We'll talk about continuing decline in vision in patients with neovascular AMD in real-world scenario. Now, in real-world studies, we often find that we are unable to match the visual improvements seen in clinical trials, and this is often associated with fewer doses of injections and under treatment. As we can see from this data, the places where they're giving fewer number of injections, we are also achieving slightly lower visual gains in these patients. It is often seen that after initial improvement with injections, the vision in patients subsequently tends to decline over a period of time gradually. And this is often associated with the lower frequency of injections and under treatment. So to summarize, in real world clinical situations, we often see that vision continues to decline in neovascular AMD patients. And this is linked to often missed monitoring visits and inadequate treatment with injections, under treatment. We'll talk about burden to the healthcare system now. Now, the burden on healthcare system is already very high because of increasing prevalence of the disease along with high drug costs and need for frequent treatment and monitoring. This has led physicians to explore different regimens of therapy. They have adopted different regimens like treat and extend so as to reduce stress clinical capacity. However, this discontinuous treatment regimen often results in delayed detection of recurrences, and this may result in some scarring and vision loss over time. In this ASRS survey, many retina specialists said that discontinuous anti-VEGF treatment is preferred by the physician and patients, even if it results in some vision loss over time. And with discontinuous therapy, it is often not possible to predict when disease reactivation will happen. It is often seen that as we increase the duration between injections, there is a higher risk of reactivation, and this reactivation may produce some vision loss and scarring, which may be irreversible with subsequent treatment. So in this another survey, it is seen that maximum number of physicians said that reducing the treatment burden and producing a long-acting sustained delivery is the primary unmet need in neovascular AMD treatment. To summarize, to deal with the treatment burden, physicians have adopted different regimens such as PRN, treat and extend. However, this can result in reactivation of the disease, and this may produce some scarring and vision loss, which may be irreversible with subsequent treatment. Now we'll talk about burden to the patient. It is seen that frequent monitoring and treatment places a heavy burden on patients, and their lives are preoccupied by frequent visits. Often it is seen that patients over time tend to discontinue therapy, citing various reasons such as long distance of travel, dissatisfaction with the benefits of treatment, burden of follow-up visits, and the cost itself may be an important factor in Indian scenario where patients are paying from their own pocket. Despite this being a chronic disease, the patients know that over a time it is seen that they tend to discontinue therapy. From this French Journal of Ophthalmology data, it is seen that 50% of patients tend to drop out of treatment after an average of 3.7 years, citing various factors as we already discussed. So to summarize, due to frequent injections, we see that patients tend to undergo treatment fatigue after a certain amount of time and often discontinue treatment. Now we'll summarize the above facts that we discussed. It is seen that the prevalence of AMD is constantly rising with rising life expectancy and increasing population in developing countries like India. And this leads to high resource utilization, and this is extremely difficult for healthcare systems to manage. In real world clinical situations, we see that vision continues to decline in neovascular AMD patients, and this is often linked to undertreatment and missed monitoring visits in these patients. Physicians identify reducing the treatment and monitoring burden as the primary unmet need in neovascular AMD, along with increasing the duration of efficacy. Patients often discontinue anti-VEGF therapies over time, and they tend to undergo treatment fatigue after some time. Therefore, there is a need for long-acting drug delivery systems so as to not only reduce the treatment and monitoring burden on these patients, but also to achieve good visual outcomes that we see in clinical trials in the real world scenario. Thank you. Yes, sir. We can move to the discussion, sir.
Thank you, Apur. We can stop sharing.
Thank you, sir.
So, Apur has given an overview of ARMD as well as what is the unmet need. So, what according to you, Apur, is the single most important factor of patient not improving, coming to you?
I think, sir,
unmet need. To my thinking, unmet need is primarily because the frequency of injections is so high, and the duration of action is say 4 to 6 weeks. And
that is, one important factor, sir, especially if patient is paying from his own pocket. Cost may be an issue, but I'm also seeing that a lot of patients where cost is not an issue, they tend to miss visits after a certain amount of time. They get fatigued with therapy, and there may be a variety of factors where the overall health of the patient is not good and they need somebody to bring them to the hospital. And there is also, over time, they see that the visual improvement is not much, and so they discontinue treatment, and then subsequently they start losing vision. But when they come for subsequent follow-up, we are unable to regain the vision loss. So there are a variety of factors.
Yeah, I know there's not one, but we have to address each one of them so that, you see, I think the VEGF load in ARMD is so high compared to diabetes or other things, because diabetes, the VEGF, I personally think, is not such a great issue. There are other drugs available, steroids and other things. So, Aditya, what do you think the difference between Germany and here?
Sir, I think, like we were just talking about this, and I think the biggest difference here is the compliance and the adherence to protocols. Again, that is compliance. And secondly, sir, because of free availability of injections at no immediate cost to the patient, everything is covered by insurance. That ensures compliance, number one. Number two, the mentality of the patients. Here we have often seen that patients, even if they are fully insured, they just don't want therapy. And sometimes, in Germany, what I feel is it sometimes becomes an overkill, because there up to 6 consecutive injections of aflibercept can be given even if the macula is dry. Now, this is, 3 to 6. So that is the recommendation. Now, sometimes you see very good response with just 1 injection. And then in India, it would be very difficult to convince the patient who has seen improvement and you have nothing to show on the OCT, no fluid or anything. And then you say you have to keep taking injections, but that is not the case there. So that is one thing.
Tirumalais, you keep treating if fluid is there, or what is your endpoint?
If fluid is there, I usually treat some. I think one other compliance issue is that many of us tend to use this key number that we give 3 injections and after that we can kind of stop, That's kind of imprinted in the patient's mind. So when they give a follow-up and, when you offer them the 4th one, so majority of them feel that, this is a disease which kind of fails after a while. So it's very important to start the conversation with an AMD patient by telling them that, see, this is a disease which is going to be there with you for 5 years. Okay. Treatment might be required for up to 5 years. And that perseverance with the treatment is what is going to end up with good vision and not just giving 3 injections or 5 injections or whatever it is. And we will show you evidence that when treatment is required. So if you tell the patient that on the OCT there is fluid, see, that's why I'm treating you and this is the lesion. When they come for subsequent follow-ups, you offer them treatment based on, see, this has recurred now and that's why I'm treating. I think the trust keeps maintained for a long time, and you can also prevent the patients from going away from the, so-called compliance.
Srinivas, hi. Hi, how are you? So the issue is, once the patient improves in vision, then if you counsel that you follow the treat and extend regimen, how do you do that, Srinivas?
For T&D, sir, treat and extend?
Yeah, no, suppose patient has improved in vision, say from 636 to 69 now. You have given 3-4 injections of anti-VEGF, and now you say, there is some SRF there, you still require treatment. Maybe you can prolong it by 6 to 8 weeks or whatever. So how do you counsel? All fluid is good, or some fluids can be tolerated, or?
Yeah, I think it's a good question, sir. I agree with most of the speakers who have discussed about the counseling points. I still feel that if the subretinal fluid is staying for a long time, if there is no drop in the vision, and I still feel we need not be so aggressive in those patients to continuously keep on injecting. We can definitely observe such patients. But if there is in the Octa, if there is increase in the vascular network, in those cases, and the patient feels that no, there is a slight decrease in the vision, in those cases, I always tell them, see here, I compare the Octa, you see here the vascular network is growing. So a vision can anytime go down. So it's better we go in for the treat and extend. So I think showing these now the simple tools are, to be frank with you, I keep a big monitor in front of the patients and I show them. When they see the comparative scans between the two, they themselves get very happy and they said, no, doctor, I think I need one more injection. I need not tell them. They themselves come back to me.
That is the best way, actually. That is the best way. Take the patient to the monitor of FA or OCT or color photograph. Show them that this is the fluid and this is what my aim is. In case if you don't follow up, this may go down. If you follow up, we can at least maintain the some vision, or the drop may be less. So this counseling, in ARMD takes a lot of time. Any views by Gunjan or Chakitan Singh or Pawan?
Very, very true, sir, actually. And sometimes OCT patients are not able to understand, sir. Sometimes, you tell them fluid, they look at, where that is.
No, वो तो समझाना पड़ेगा machine पे जाकर.
No, sir. I was just telling that, but Octa, if you show them, no, sir, you show them those vessels, those branches, those medusa head kind of a thing, that they are able to appreciate very well. See how this was now it is better, worse, then they are able to tell you that, yes, please treat, so they are able to understand much better, sir.
So I think with these few words, I think let's move on, because we have to respect the time also. I will take a couple of minutes to, share my initial experiences with Brodusumab.
Introduction to you, sir.
We already done. You joined late.
The Bhishma Pitama in ophthalmology. Only one sentence. Go ahead, sir.
So, you see, we started very hesitatingly, because I still remember my first patient was 1st of January 2021 only. The reason we started was because there were some reports of vasculitis, and our entire retina management group was so scared that nobody would venture into it. And I had to bell the cat, being one of the senior most person there, because what I always believe is, if there is a drug, either discard it or use it or come out of it. Even when I was in RP center, we will have all the pituitary machines of Alcon, of DORC, everybody. Then only you can come out, or Appa Swami. So then only you can come out with your experience. So this Apoor has already told, but what he has also told is it's unmet needs are there. I believe that VEGF is an individual thing, but in ARMD, it's not, it's one of the highest compared to DME, where a lot of other factors, inflammation and all, play a part. And a lot of pivotal trials on ARMD, huge numbers are there. And fluid on OCT is one of the indication apart from OCTA and other things which say the disease may be active. So management of ARMD is various trials. This is an incomplete slide. Various trials you see here on all the drugs, anti-VEGFs, various molecules, the latest kit being the brodocimab, lot of regimens. I always start with monthly for 3-4 months, and most of my patients then shift to treat and extend. In fact, 90% patient, I try to shift them to treat and extend. Unless they, have issues, then we bring it back. We were just talking about fluid, and Apoor very nicely told about so many unmet needs. And there's a disconnect, as I started in the beginning, between trials. And Aditya was telling, in West, people, 6 injections, people will definitely adhere to because, as Apoor was saying, somebody else is paying. But real world, as in India, where insurance penetration is less, there's a disconnect. An endpoint, as was being discussed, is not known whether we want to eradicate all fluid. SRF may stay. SRF is known to be relatively friendly. But a caveat is it has to be associated with a stable visual acuity. All SRF may not be good. In any case, I try my best to eradicate all these fluids. Subretinal, sub-RP, intraretinal. Intraretinal is the fluid which is associated with the maximum decline of vision. So these are the various types of fluid, various compartments of fluid. So I still believe that all fluid is bad for retina. Retina तो dry होना चाहिए ना. भगवान ने retina dry बनाया, भगवान ने fluid नहीं बनाया. Just because we can't eradicate, we don't accept our defeat. We say, अच्छा ये fluid is stable, vision is okay. Let's wait. And this is a borrowed slide from this new study which shows the association of fluid and the visual acuity. So brodocimab, once it came, everybody thought, in fact, Praveen Duggal was shouting from all the stages, that's the newest kid, and we'll have a revolution. And the advantages of brodocimab being the smallest molecule on a molar basis, a lot of molecules can be packed because of the small size. At 12 times, then aflibercept 22 times of ranibizumab, primarily because it's a 26 kilodalton molecule. And this is again a borrowed slide. You see the size. This is Avastin, this is ranibizumab, and this is aflibercept, and this is short brodocimab. So this is again a borrowed slide from Hawk and Harrier, which shows the proportion of patients affected by fluid vis-a-vis the visual acuity. So then suddenly alarm was created in the entire world that a lot of inflammation. In fact, the label also says there's inflammation, retinal vasculitis. And a lot of, immediately, a couple of studies came up, risk of vasculitis, risk of severe visual loss, 3 cases reported, bilateral vasculitis reported. So everybody was caught in a fix. In fact, the entire India was virtually doomed. Nobody was trying. So we started in a very small way. So as is usual, we tried in a poor prognosis patient. So this was one of my first patient. You can see the date is 1/1 actually when I gave the injection. So this patient, right eye was good, but left eye, she was advised injection. She could not take. This was the only treatment naive patient I had. So this was the OCT picture. You can see a type 2 kind of CNVM with intraretinal fluid here. Vision was not very good. So I frankly told her that I want to try this injection if you want. She had already Googled it. She said, I want the best. So you see, this is 1 month, exactly 1 month, 27/1. So I gave on first. And you see to my thinking, to my surprise actually, all IRF gone. All this cysts, all this fluid went away. OCT showed some decrease. More important that patient was happy. In fact, the daughter of this lady said, "Sir, दूसरा injection आप लगाना चाहो तो लगा दो," because she finds improvement. But since we know there is a scar here, so I told her, "We रुक जाते हैं, let's wait." And this was the second patient which I had. This patient already had received more than a dozen injections of aflibercept, and this was, after 4 weeks of injection. Notice the whole sub-RP fluid has virtually decreased or flattened at somewhere. Apart from this small SRF and IRF, phenomenal response in the sub-RP fluid also in this patient. Again, patient vision was maintained because there is hardly any scope for improvement because patient was not a treatment naive patient. So this was another patient of mine who had this is the lower one is pre-operatively unresponsive to 3 ranibizumab injections, and in 1 injection there was some ERM also, and you could notice some decrease of IRF intraretinal fluid here. This was my 4th patient, in fact. This was a lady, 63 years old, and upper one is the pre and lower one is post. This was a miracle actually, because once I showed this OCT to her, you see the entire fluid, both the SRF as well as IRF. The drying effect of this molecule was after this patient only. This was my 4th patient. I developed so much of confidence that even my fellow started saying, "Sir, as a patient, first choice should be bevacizumab." And this lady improved in vision also, although margin was only 1 or 2 lines only. So subsequently, this lady had recurrences after 6 to 8 weeks. We re-injected, and this was pre-second injection, and this was post-second injection photograph. Again, the nice contour came back, and all this sub-RP fluid, SRF, virtually gone. 3rd injection. This was before 3rd injection. The upper one. This is every time I give this injection. This is generally given Q8 or Q10. In fact, she walks in at that time only. So this is a summary of this. In fact, she has received 4th injection in the month of August only. So I don't have that picture as of now. So she has received 4 injections of Paginex, and this is the final observation here as far as OCT. A dramatic improvement in OCT. This is a summary of my 5th patient, elderly gentleman, 82-year-old male. Now this gentleman again has received another injection. This is 6 injections in this patient, 6 injections of Paginex. Previously, he had received multiple Eylea injections. I have just photocopied this OPD paper only. And this one-eyed patient, practically one-eyed, because left eye has a scar, right eye, we are still able to maintain 6/9 vision. And these are the OCTs of this last photograph which I showed. You see pre-op, post-op, 574, 466. ERM obviously is there, but notice the SRF going, notice the subretinal fluid responding. This is before 3rd and after the 3rd injection. Again, notice, although there was a recurrence, because the gap this time was more, the response again was very dramatic. This is before the 4th and after the 4th injection. This is 5th injection, pre and post. So this is by and large a summary of patients which I have done till date. And if you see the visual acuity, the difference is not dramatic, because most except one, by and large, all patients are resistant patient to previous anti-VEGF injections, and most of them have received more than 5 to 6 injections. But what is noticeable is this green, column where there is a dramatic drying effect, which is very, very significant from 518 to 371, and this is consistent. There's hardly any patient where there's no drying. So just to have a different way of representation, visual acuity by and large same height, but dramatic reduction in the OCT thickness. So what do we do? How do I today approach my patient? Fortunately for me, I followed up most of my patients, at least first 5 of my patients, virtually 1 day, 7 day, 2 weeks, because there was a scare in my mind, because the inflammation now. And I have photographs of all these days just to show that there's no vasculitis, there's no inflammation. Fortunately for me, none of these now 20 eyes have any inflammation or vasculitis. We did indirect, we did anterior segment examination, vitreous examination, OCT also, and photographs. So one thing is very certain, that there's a marked drying effect, and there's no double second opinion about that. How do I apply in my day-to-day practices? That I talk to the patient, talk, explain everything. So we study trend of reduction and BCVA improvement, but whatever the patient is already on, if with the present regimen of any anti-VEGF, whether it is ranibizumab or aflibercept, if it is going positively, then we don't touch, we don't change anything. But if the fluid is not responding or the BCVA is decreasing, I today do not hesitate to give them a positive choice that you should try this drug, ranibizumab. Although we talk, we have a separate consent form for this. Tell them, I write to them that there's a reported risk of vasculitis, but you have to take that risk because the response, you have already taken so many injections, you should take. The other thing is, as of now, I am not doing monthly dosing in any of these patients. I mostly do Q10 or Q12 or do PRN. And treatment naive, I think I still have to have some data so as to share with you. But in this initial 20 eyes which we have done, I personally think it is best suited for patients who have, type 1 occult kind of CNVM or IPCV or RPEDs, because of the dramatic response which we see here. Thank you. This is what I thought I'll share with you. So I'll love to have comments.
Yes,
Thank you, sir. Sir, can I ask a question, sir?
Yeah, sure.
Yeah. So in a patient, if SRF or intraretinal fluid has resolved and there's a persistent PED, will you consider switching therapy only for a persistent PED to brolucizumab from other anti-VEGF injections?
No. Only PEDs we don't. Only PEDs we don't treat. In fact, unless it is symptomatic PED or there is, some ICG hotspot is there. Only PED I would not.
Yes, sir.
So as what a couple of patients showed, there was no isolated PED.
Right.
They had sub PED fluid and they had associated SRF as well as IRF also.
True. Yeah.
Can I ask a question?
Yeah.
See, whatever literature has reported, majority of these patients are female patients.
Yeah.
So how will you decide what you showed that first patient was your female patient and one-eyed?
Yeah.
So I am slightly worried that while selecting the patient, especially one-eyed and that to a female patient, I mean, how would you counsel, or would your decision making would slightly differ on basis of male patient or female patient, or it doesn't make any difference while choosing a patient?
So shall I tell you honestly, the day on 1st January 21, I did not know about this, honestly, male, female. I did not know. This was my later knowledge that I came to know that 70-80% of whosoever has a negative, reaction or intraocular inflammation or vasculitis are female. So at that point of time, I did not know. So I don't know what others feel about this. That do you offer about female patients? Yes, Aditya.
Sir, just wanted to interject. Actually, what, apart from the gender, what they have generally identified is that it is patients who have received very frequent injections. I will not say multiple injections, but very frequent injections, every month or so. They are the ones who are definitely developing, or have a preponderance towards developing this intraocular inflammation apart from the gender. And one reason that has been purported for that is that the higher molar concentration of this molecule as opposed to, say, ranibizumab or aflibercept. So, we are already aware that multiple anti-VEGF injections do lead to sustained IOP rise. In fact, we published on this a couple of years ago. Unlike Ozurdex, the rise is sustained here. And one of the reasons that has been hypothesized is that these micro-degradation products go and clog the trabecular meshwork, and that the trabecular meshwork is anyway prone to degeneration and overall effect in AMD cases. So one of those reasons was that, repeat injections, as what happened with the Merlin study. So the rate of inflammation doubled, from 4.6, I think, to 9%. So that was
I'm aware of the Merlin study and why Novartis had to, interfere in that. But female gender and correlation with that, I think this is what Pawan was going to ask.
Yes, yes.
And what is the explanation for that female gender?
I think the overall predisposition of
KRMD
women towards autoimmune disease, coupled with this high concentration, molar concentration within the eye. I think that is the hypothesis currently doing the rounds.
I have a question.
Yeah.
I actually wanted to know, has anybody used it in post-vitrectomized eyes? So how is the response compared to other anti-VEGFs? Like, we know that Avastin doesn't work very well if you give in a vitrectomized eye. So has there been any experience from anybody? And second, since it causes some amount of inflammation, so is there any preponderance of more number of cataracts, or, can we give it in a aphakic patient, or it should not be given? That is my question.
Yes, anybody would like to take this?
The vitrectomy is just one. It has worked more or less the same as it was a vitrectomy for vitreous hemorrhage secondary to AMD.
I have not used in vitrectomized eye, but other anti-VEGFs, the biomechanics and the pharmacokinetics, there is a divide actually. And by and large opinion is you should not change the dose of any of the anti-VEGFs.
I have used in one of the patients, and I'm going to show that patient vitrectomy.
Okay, let's move ahead and let's have some more, patients there, and then I think this discussion will get more heated up by this. Srinivas, can you show your real-world slides?
Yes, sir. Thank you. Thank you so much for the kind introduction. I'll just move on to the presentation.
You're going to show 92 slides.
No. We're just going to show around 6-7 cases. That's it. Yeah. Thank you, sir. Thank you, Lalit sir, for that kind introduction. Thank you, dear panelists and speakers. Thank you, DOS and Novartis. So I have no financial disclosures in this product. So I'll not go into the details. This has already been described. But interesting thing is what we see is 5.1 injection if you want to maintain it. 7.9 injections are required if you want to improve from the baseline to around 15 letters. That is around 3 lines of Snellen's. So I'll just go quickly into the cases. So this was a 71-year-old man who presented to us with blurring of the vision. He was diagnosed as right eye CNVM, multiple intravitreal injections, and he came for the second opinion. Here you can see a beautifully presented polyp underneath here, and the OCT itself, and the OCTA confirms the vascular network. Now, FFA and ICG was done in this patient, and FFA and ICG shows the polyp very well. And this is corresponding. If you see this point is corresponding to the polyp here on the ICG. And again, the second point is again corresponding to this line here. So started on aflibercept 3 monthly doses followed by PRN, received multiple doses, if you can see here, of the Eylea. And then these are the various pictures where the patient was put on. And this was the dead tree kind of appearance on the OCTA. And one fine day, the patient stopped responding to aflibercept. Post 2 months, in fact, there was increase in the SRF. We shifted from brolucizumab to aflibercept to brolucizumab. And here you can see there's not only the resolution of SRF, but also the FIPED, what we call is the flat irregular PED, that had also drastically come down. And the patient presented 3.5 months, that is post brolucizumab, on the day where the patient had recurrence. So we can say this lasted nearly around 3 months. Another case, you can see the polyp here underneath, tall notched PED here. And if we see the flow OCTA, signs of PCV was seen. FFA and ICG confirmed that it's a polypoidal choroidal vasculopathy, advised by aflibercept, but financial reason opted for brolucizumab. And you can see there is a good response of the decrease in the PED and absolute absence of the SRF here. This is another case. She has been, I think, been on anti-VEGF since 5-6 years for now. This is the MULPED, or what we call it as the multi-layered PED with type 1 CRD, type 1 CNVM with hyperreflective dots. This is the OCTA showing the vascular network. Brolucizumab was given, and this was a keen reader. She's a very keen reader. And she says that apart from the previous all cocktail of injection, she first noticed that this injection has a little bit of early improvement as compared to the previous injections. And initially she was responding to 3 months here, but again after 3 months she had a recurrence, and then subsequently she started tolerating only for 2 months. So now she is still on 2 months regimen. So earlier she was on 3 months, but now she has come back on the 2-month regimen. Now this is the another orthopedic surgeon who is a 47-year-old. Is a case of high myopia. Left eye, he has received multiple ranibizumab injection. Sorry for the little bit of noise level here, but this is another doctor who said that definitely this has a early kind of recovery, and the contrast sensitivity what he mentioned was something I had to believe because he is a doctor, and he said it is quite early and I'm seeing much better even in the low light or the dim light. And now it is 2 months he is still tolerating, and we are yet to see for the next month. Another case where we can see again there is a component, PCV component here. You can see FFA and ICGA. There is a branching vascular network here on the ICG, and this is what I was mentioning about in the zoom, and corresponding sub-RP network and the FIPED on the OCT and the ICGA. This is the corresponding on the OCT and ICGA. Multiple injections of ranibizumab, bevacizumab based on their economic pattern. And brolizumab was given. Now you can see there is a good response to this patient, both on PED as well as for SRF. 2 months, patient is doing well. And this is the pre-injection. So the patient tolerated for nearly 3 months, 3 weeks in this case. So again, the patient is doing pretty well. Now this is the patient who tolerated nearly for 4 months. After 4 months, now we can see there is a slight increase of the SRF. And again, the patient was given and the patient is doing still well. So this patient tolerated for 4 months. This is the another last 2 cases which I'm presenting. She also had multiple injections. So this is the Aurora and the retained PFO with the surgery done before. And here you can see there's the SRF has come down decently well. And again, she used to have recurrences. So 2 months, then again, follow-up is. So again, when we looked into it, she already has a hyalinized central trunk on the OCTA, which shows the signs of chronicity. This is the other eye. The pre-brolizumab, when we gave the brolizumab in the right eye, 1 month, the patient was doing good. Now it is nearly 5 months that the patient is still doing good and she is still maintaining 6/12 vision in this eye. Now this is another case where you can see there is a left eye diminution of vision. This is the chronic case where you can see this chytic kind of spaces here, and these cases also you can see they responded pretty well. Now this is another last case of mine which I just wanted to show because I saw him today. This is the another case of PCV. You can see the feeder vessel going into this substance, and you can see a small polyp here. So this is probably a type 1 PCV, and you can see a PED here, and subsequently you can see here, this is what I just saw it today. If you see the date, it is 2nd of October. The beautiful regress of the polyp, PED as shown by Lalit sir. Similarly, here if you can see there's a intraretinal fluid spaces has come down. I'm just showing the video. You can see the comparison from the last month to this month. There's complete absence of the large PED which was seen before 1 month. So this is just today's patient, so I thought I'll mention it. So this is the OCTA showing a vascular network here. So in our institute, excellent response we have seen in occult CNV, PCV, and chronic non-resolving SRF and IRF. The maximum duration of action noted in our institute was around 4 months and 2 weeks. I would like to acknowledge our colleague, fellow Dr. Rajeshri Salvi, for pulling up all the cases for me. Thank you very much for the patient listening.
Very nice photographs and very compelling, reason to believe that this molecule works. 2 things I learned from your presentation. One was the duration of action. You see, some of your patients have 3 months, 4 months, and one 5 months also you showed. But average was somewhere between 2 to 3 months.
Yes.
And the other thing which, fortunately for me, you agreed upon that was occult CNVM, PCV, and non-responsive. So today, how much confident you are to give it in a naive patient?
I've
Because
started, sir.
if you are so happy with the chronic non-responsive CNVMs, and you see the beauty of your presentation was the virtually normalization of contour in couple of. So what stops you from doing it in naive rather than a chronic, non-responsive?
Sir, very recently we were introduced this. To be frank with you, I have no financial interest either in the aflibercept or in this Pagenax molecule. But I work in a tier 2 city, sir. What mentions to us is the paying capacity of the patient. Not all patients are insured. So what matters to us is how much money do they spend.
Yeah.
If this patient is, we are able to do at a 35,000 rupees or 30,000 rupees maximum, if you can charge these patients, and then if you can give around 3 months, then why not? So this we started. We have already given it to 15 naive patients. And
so MRP I think is how much?
It is around 25, if I'm not wrong.
Yeah.
29,000. The MRP is 29.
29,000.
But I think the what comes to the hospital I'm talking.
Yeah,
so,
25.
So what I'm asking is, because if the duration of action is say 2-3 months, and if you calculate the economics of everything, of all the anti-VEGF, there have been a lot of papers published only on economics of anti-VEGF injection. And hi Maiti, how are you? I would request Maiti, because he and Aditya to look into it. The economics of anti-VEGF injection means if patient has to come every month, get a consultation, get an OCT, one relative accompanying. If you work out the economics, that 29,000 becomes virtually less than the cost of even ranibizumab also. Believe me.
Very true, sir.
Avastin, sir. It approaches Avastin.
Yeah, that's what I'm saying. So that is the, you see, second patient which you showed, Srinivas, you said for the economic reasons we injected this. I didn't understand that.
Sir, that's what I told you. The aflibercept we charge 45. We just give it at a cost price. As I said, in tier 2 cities, it is very difficult to counsel for the second or third or the fourth injection, sir. They just keep hopping from here and there. But now I think aflibercept has the Bayer has now started the ILIA for You program. But still, giving that initial 45 is also difficult for few patients. So that is what we have seen in tier 2 and tier 3 cities. And us being a referral center, we get a lot of people from the tier 3 cities and basically from the villages. It becomes really impossible to counsel them for any of these higher injections. So that is where, even if there is a difference of 10,000 rupees, people would like to go for that.
I agree. But you see, 2-3 points which you raised. One was duration of action and economics of anti-VEGF. Then because it beats ranibizumab and aflibercept also. Like Aditya saying, it now approaches the cost of Avastin. Rajiv is there, or is he joined and went away? I think. Anybody would like to comment on that? Otherwise, we move because we have a couple of more presentations. Let's now hear Manoj Khatri. Manoj Khatri, are you ready for your presentation? Anybody, Gunjan, any comment you want to make?
Or any incidents of vasculitis or any incidents of inflammation in your cases or anybody else's cases? I think Dr. Narayanan had a case of severe vitritis in LV.
Yeah, that was the first patient. I know I was traveling. That was a total different scenario altogether because it occurred on the same day. It was more or less infectious. It was a procedural kind of issue, not because of the drug. I remember I spoke to all the Novartis people and I spoke to Raja immediately. That was on the same day, within few hours, it was reported.
And I think Manish Bapai also in Nasik, sir, he also had one inflammation, if I'm not wrong. So any other inflammations which you know of?
Srinivas, what about your adverse events?
No, sir. Till today, I think more than 120 cases now. So touch wood, God's grace, I haven't seen that. But still, as Dr. Singh is saying, we need to be a little cautious for still more time. I think it's too early to comment on this, sir. Of course, I have gained confidence and we are giving it in one eye. We are giving it in even the doctors also who are still operating, which I showed the orthopedic surgeon is still operating. We are giving it, but definitely we have to counterbalance both the effects.
Okay, let's hear Manoj Khatri.
One.
Thank you very much, and good evening once again, everyone. Thank you, DOS, for the kind invitation again. Sir, are my slides visible?
Yes, carry on.
Yes.
Can hear.
Yeah. So just let's move on to the cases. So a short real-world experience. We started using brolucizumab in the clinical experience right from the word go when they launched, and one of the earliest patient treated by me, as what we are discussing right now, is whether you want to treat a female patient and with a suspected pathology of PCV and in a treatment naive case. So this was one of the cases. This patient had a query IPCV type of a CNVM and fairly young patient, and being a female patient, you always think whether you want to start treatment or not. This question was always there. But we convinced the patient, and initially when we started using brolucizumab, all these patients were seen by myself before injecting thoroughly, and also we followed up for initial 3 months every 2 weeks. So we just wanted to not wanted to miss IOI in any of the patient. So this typically what we get a response after 2 weeks. What you can see here, a notch PED with SRF, flattening quite well, giving very good anatomical and functional outcome for the patient. A happy patient, and over a period of time, she was lost to during the second lockdown. She was lost to follow up and had a recurrence. But when she came back with a recurrence just after the one injection, this was about 3.5 months post first injection, we again convince the patient and stick with brolucizumab, and this is what we get, immediate favorable response. So these type of patients can be treated quite safely in short clinical experience what we have, and they do fairly well. The idea here is to reduce the number of injections over a period of time, so that giving them the quite effective treatment. This is another question raised by Chakitan, like, can we give it on a patient who had a vitrectomy surgery? So this patient not only had vitrectomy surgery for retinal detachment, he also had a penetrating keratoplasty for decompensation of the cornea, presented with an occult CNVM from a charitable being patient. Novartis was kind enough to give us a free vial for this patient. And we straight away injected brolucizumab, and over a period of time, within few weeks, you see here is a very good response. And this patient, just with one injection, did quite well, and the CNVM regressed quite effectively. Over a period of time, he had an episode of SRF after the scene after about 6 months of initial presentation. Given him one more injection, and this patient started showing a good response once again. So as this type of CNVMs can be, seen which are little recurrent in nature and sometimes little frustrating, but I think brolucizumab has an edge over other molecules here to minimize the number of injections. Now coming to straightforward cases of neovascular AMD, this is a 82-year-old female patient treated by me in the past in 2018 and 2019 with about 6 aflibercept. I will not say that the patient was not having good response. The patient was having very favorable response, but again, she was lost to COVID-19 follow-up. And when she came back in November 2020, this kind of a, Vengeance looking CNVM, what you see here with SHREM, you always have a doubt how to go about the treatment. Straight away, we gave her brolucizumab, as what we can see here, with a very good response. Even the SHREM component, which was quite intense here in the subfoveal area, you see here it's regressing quite well. Over a period of time, we kept this patient after on a loading, and after that followed by treat and extend protocol, and she did quite well over a period of time after receiving 3 loading doses of brolucizumab. And this is one of the last follow-ups. What I have is like a little bit of scarring is here, but this patient had 20/30 vision, that is 6/9 vision over a period of time, and did quite well. In the same lines, one of the other patient what I have with the chronic outer retinal changes, where you always are in a dilemma. This patient was treated by one of my colleague elsewhere. She was mother and an ophthalmologist. It's not that they have not done a good treatment; they have done a very good treatment. But when they came to me for a second opinion, I said, let's shift over to brolucizumab, because already 4 injections of other anti-VEGF agents were given. Because of the chronicity of this membrane here, I thought brolucizumab will be a better alternative, because most of these patients, even in the West, are switchover therapy. The moment we give brolucizumab, this is what we achieve in 2 weeks' time. The entire outer retinal structure started behaving normally. looking normally and have a good anatomical and functional outcome over a period of time. This patient had again recurrence after 6 months or so of the initial injection, because she received only one injection. And over a period of time, we gave her, continued with brolucizumab treatment, and again got back to the 20/40 vision what she was originally achieved with the first injection. So this kind of outcomes are achievable in real world scenario. The only thing is that we have to follow up this patient quite closely. We are still, even if the patient is on PRN type of a treatment regime, we are following them on monthly basis and see whether at what stage you need to re-inject these patients. As Srinivas told us beautifully, that the interval may range from 2 months to 4 months. Another case, this is a male patient treated by myself in 2019 with 4 aflibercept. Again, lost to in the first lockdown due to COVID-19. Came with a recurrence. This time again, I was thinking rather to wait and watch, straight away start with brolucizumab. We did the same. As what you can see here, within 2 weeks of the first injection, this is at presentation, recurrent CNVM, and 2 weeks response. You see such a nicely regressing CNVM. Over a period of time, again, this patient received 3 loading doses followed by PRN, and what you can see here is a very favorable response. Another patient of mine, 72-year-old male with a notch PED. Always we are little wary about treating this patient because there is a high incidence of RP-RIP and other complications, and we don't want to just treat the PED as so told by Lalit sir. We should be very careful in selecting this patient. But this patient, he was initially on treatment with pre-lockdown only with aflibercept, so we kept this patient on aflibercept. There was a fair amount of outcome at the second recurrence. I will not say there was no response, but when I started noticing the fluid, especially in the subretinal region, which was increasing in the quantity, I shifted this patient from aflibercept in November 2020 to brolucizumab, and this is the dramatic response we get. So this is in November 2020, aflibercept after second aflibercept. And what you get in December 2020, you see entire PD flattens out with all the fluid which is get absorbed. And over a period of time, this patient has done very well. Now he has 20/20 vision in this eye and maintaining the same anatomical and functional outcome. Couple of last cases to share with this August audience for today. Another 77-year-old male, occult CNVM, typical occult CNVM, treatment naive eye. Straight away started with brolucizumab. You get a very good anatomical and functional outcome. Over a period of time, this patient do maintain good amount of visual acuity, but this patient had a recurrence again after about 7 months of initial regression. We counseled the patient again. This time the patient himself asked, "Sir, wo naya wala injection chahiye." So the patients are also familiar nowadays, which injection we are choosing for them. So the moment we showed them his OCT, he was quite convinced that he wants brolucizumab, has done quite well over a period of time. One of my last cases for today evening, this patient had bilateral CNVM, and looking at this chronicity of subretinal fluid, I was even thinking of rheumatogenic retinal detachment for this patient. But after thorough clinical examination, we were quite convinced that the patient has only occult CNVM with extensive SRF. And this patient, once you see here, with one injection itself, the entire pocket of this SRF, which was going up to the equator, completely resolved. So this was quite dramatic response what we have seen in this patient. The fluid absorption is quite dramatic. So that gives you the confidence that you can treat this patient straight away with brolucizumab, and so maintain them over a period of time. This patient though has some amount of foveal scarring here, but has maintained a vision of 20/40 over a period of time. Had a recurrence after about 7 months of initial injections after the post second lockdown, but the recurrence was not as severe as initial presentation, and did quite well even after treating for recurrence, though there was some kind of a foveal atrophy which is setting in. Vision dropped from 20/40 to 20/80, but mind you, the entire CNVM complex quite drained out and flattened out quite nicely. So gave us the confidence that these patients can be treated even for recurrences over a period of time. So to summarize my talk, we do get this kind of wow effect in the real world scenarios as well, but as we have discussed time and time again, choosing these patients, following them up is quite critical. And also we are learning from each other's experience, not only from the global platform, but even from Indian counterparts. And once we have more and more data available to us, I think we are heading in a very right direction, so that the number of injections will come down and our patients will get the maximum benefit out of our clinical practices. Thank you very much for a patient hearing on the wonderful opportunity given by DOS. Thank you once again.
Thank you, sir.
Wonderful presentation, must say, Manoj. Excellent slides again. One thing again I learned from your presentation was wow effect, especially in notch PD 2-3 patients which you showed. This wow effect in ARMD is not usually in vascular blocks. I have heard about wow effect, but ARMD and wow effect, Tribulesh, have you heard about wow effect which Manoj has been emphasizing in a couple of slides?
I think I have seen a few, sir. I have, for a fact that when it came, I had given in pathologies other than AMD, which I'm not supposed to discuss on the forum. But after seeing that it does work well in chronic cases, I did offer it to a patient who came and was treatment naive. And the wow effect was not only to the patient but also to me, because the membrane which was there was not visible when we did the OCT after a month. So in that way, this drug has actually kind of changed a little with reference to how we are.
I agree, Tribulesh. Honestly, in big RPEDs or PEDs, notch PEDs or symptomatic PCVs, all these things, this wow effect I had not seen with other anti-VEGFs. That's what, because I showed around 20 slides. वाउ इफेक्ट जो इसमें आया है ना, वो शायद मेरे को पहले इतना अच्छा दिखा नहीं था, स्पेशली ऑन ओसीटी. Like you said, more for surgeon than for patient sometimes. That's okay, but as long as if surgeon का होगा तभी तो patient को impress करेगा ना. That's also very important.
Totally agree, sir. That
yeah, because if I see a wow effect on OCT, because that 63-year-old lady which I had shown, but she is normal OCT. Believe me, SRF gone, RPD fluid gone. In fact, I had to question भाई ये उसी patient का है. Then so that wow effect, especially in RPE fluid and SRF, had not seen. That's what.
In this, you can see both, sir.
Yes.
Both the patient and the surgeon are wowed by the results in a few cases. So that was a little.
Like I said, the surgeon has to be happy. So then only. Anirudh, what do you say?
Agreed, sir. Everything.
Yes, sir. Most of the cases, the doctor is actually happy seeing the effect of in CME especially. But this, I think, using this molecule, the patients are also actually happy for the first time.
Sir, in fact, to be frank with you, Lalit sir, the chronic cases, they will never be happy. They will just have either 3-letter or 4-letter or 5-letter if you do ETDRS. But if you show them this OCT and show them this dramatic improvement, suddenly they become happy. They said, acha hua hai, acha hua hai.
This is what Tribulesh was saying. This is what
Ultimately agree for the next injection also if you want to.
Yeah, correct.
Sir, I have...
Manoj sir? Sir, we saw you following up the patient 2 weeks after injection.
Is that was only for initial 3 months. That was only in October, November, December, because that time we were not very clear on IOI guidelines. The scare was
absolutely. Of course, that was primarily because apprehension. Whenever we start using, it's not that all patients now I follow up every 2 weeks.
Yeah.
Initial 4-5, once you read about inflammation, people scare you. Then I follow that 1 day, 1 week, and 2 weeks and 1 month initially. But now I don't do it because honestly speaking, I have not seen it till now. The day I see it again, I may.
So is there a specific time frame we can expect inflammation to show up, if at all it happens in rare cases?
So most of that.
Manoj, please.
No, please go ahead, sir.
No, please. What I think is literature, whatever I read, and I read Anirudh's paper also, and other work by Dr. Sharma from Coimbatore, as well as Aditya, that 2 weeks I think is the maximum patients are reported within 2 weeks.
2 weeks to 30 days, sir. You're right.
Yeah.
That's
After the second and third dose also.
And also after repeat injections. It's not only the first injection is showing IOI.
Third injection also.
Mostly after second or third injection, people have seen that. So that is what is also there.
Kunjan, any comments on whatever?
Actually, I have been using this only with a gap of minimum of 8 weeks, not monthly.
Yes.
Ever I have not used in any of my patients. And moreover, after using this, I have almost stopped using Eylea. I have started giving this brolucizumab only. And after a few months, initially I was asking the Eylea people whether there is any scheme, because I had heard that they are giving schemes to big hospitals and the people who were using very frequently. So in past 2-3 months or 4 months, they have come up with the new scheme, which is now matching the cost of brolucizumab. So this itself shows that this molecule is coming up, and it has come up in a very good way, and it is helping us and our patients very well. So I think Eylea is coming down, and Pagenex is coming up. Maybe over time, Accentrix will also go down further whenever they get the approval for the diabetic cases and others.
You see, a lot of us off-label. You see, Srinivas showed one slide of myopic CNVM. I think Anirudh has, Matthew has a lot of experience on diabetic also. Off-label we are doing, but I agree with Gunjan that as of now, approval is not there for these conditions. Other thing, Manoj, your presentation brought in very clearly was, again, the duration of action. You see, a lot of your patients came because of COVID era, or where you see follow-up is uncertain, or patients come. Then again, if patient has a recurrence or a rebound, you give the second injection, response is again very.
Yes, sir. It's very favorable response. That is quite encouraging.
Yeah. So I think with this, let's move on to Dr. Aditya.
Can I?
Yes, sir.
Yeah.
In one point, please.
Yeah, please. Carry on.
Actually, sir, in the West, there has been an incidence of intraocular inflammation and occlusal vasculitis. But in India, I think it has crossed 3,000 doses, I think now.
6,000, more than 6,000.
6,000.
So there have been no inflammation, or maybe very little. So
we will come to that, Chetigan. Let's finish these two. We will, because I think these two talks are significant, because both Aditya as well as Dr. Mehti have published there in index journals about data from India. So that publications add. You see, once the publication becomes indexed, like I remember once we published data on Razumab immediately caught fire. So therefore, I have been impressing on collection of data, and I'm thankful to Dr. Mehti as well as Aditya for publishing, because once publication comes in index, then the confidence level of any average person also increases.
Exactly,
So
sir.
let's hear Aditya. Let's hear Mehti, and then we will come to your point, which is very relevant. And I have 3-4 slides for that also.
Sir, thank you very much. Thank you very much. And it's an honor to be presenting here on this elite forum. These are just pictures from our clinic in Germany. And I'll straight away go to the cases. I'll just present 2 or 3 cases to put things in profile. So this was a 74-year-old retired physician who presented to us with metamorphopsia since 4 days and diminished reading ability. So the vision in the left eye was obviously affected. The anterior segment examination was normal except for the presence of pseudophakia. And the clinical photo, the angiographic sequences, and the OCT were all in line with a type 1 CNA. Now, just to give everyone a heads up, in Germany, the standard of care is aflibercept therapy, and the standard protocol that is followed is the treat and extend protocol, which means 3 to 6 monthly injections, followed by either 2 weekly or, after publication of the Altair study, 4 weekly spurts. So in this patient, unfortunately, despite 6 consecutive injections of aflibercept and 6 consecutive injections of ranibizumab, he continued to worsen. So we see progressive involvement of all compartments with fluid and also a progressively widening choroidal cleft. This continued until February 2020, from November 2018 until February 2020, at which point in time he was finally switched to brolucizumab. The first injection itself, like Lalit sir or Dr. Manoj Khatri alluded to, had the wow effect. We see complete disappearance of fluid from all compartments and a significant reduction in the size of the choroidal cleft. The second injection, given 4 weeks later, effectively sealed the matter. He had no recurrence at 8 weeks, but at 12 weeks, we saw this early recurrence here in the center, this little bump. So we injected again. This patient has been maintained ever since on a Q12 dosing for the past 15 or 18 months now. So this was a straightforward PCV case, a lady, again, one of those cases which have a preponderance to inflammation. So this was after the first injection, second injection, and third injection. So again, like Dr. Gunjan just referred to, for all of these patients, we have been injecting a so-called loading dose, but every 8 weeks instead of 4 weeks. I'll just come to this slide later. This is, the occlusive vasculitis that people have been referring to. If there's time during the discussion, I would just like to elaborate on these 2 slides. Before I come to the REBA study, I'll just present one interesting case. This was a 65-year-old male who presented to us first in April 2017 with metamorphopsia and decreased vision in the left eye since 3 days. He also had a history of recent cataract surgery a fortnight ago. The vision was not too bad, but the amsler test was positive. He had had his FFA, OCT, and Octa done elsewhere. So I apologize for the poor quality of the images. These are scanned images. So what we see is that the entire area of activity lies between the disc and the fovea. Now, in this patient, interestingly, the right eye has always shown subclinical activity with CNVM, but he has never been symptomatic in the right eye, which until April 2021. So what we see here is these are pictures from the right eye. We see progressive involvement of the foveal, not the foveal center, but at least the macular area. But until April 2021, it never encroached upon the fovea. Now, as far as the left eye goes, despite 20 or 30 injections, we tried everything: aflibercept, intravitreal ranibizumab, the biosimilar bevacizumab. He continued to worsen. To cut a long story short, given the close association between cataract surgery and the explosion in the CNVM activity, we had always advised him a combination of steroids and anti-VEGF, which he had initially declined because of the possible side effects of steroids. What ultimately worked in this patient was a combination of the intravitreal dexamethasone implant with aflibercept. We were able to completely dry the macula, in spite of course the subretinal fibrosis and destruction of outer retinal layers compromised the visual gain. But 6 weeks down the line, we were back to square one. At this point in time, brolucizumab had become available, and this OCT scan was taken in the UK because he had moved to the UK after the injection. Was taken 6 weeks after the first brolucizumab injection. So except for this little bump here, we see a considerable drying of the fluid. This is the right eye. So we see, worsening involvement, nearly encroaching the fovea. Now, this scan was taken in April 2021. The top picture belongs to the right eye, the bottom picture to the intravitreal inflammation with continued, or bilateral brolucizumab injections. We advised aflibercept for the right eye. For the left eye, we continued with brolucizumab. So this is the right eye. The right eye is doing well with aflibercept. For the left eye, in April 2021, we injected brolucizumab. This was taken in May 21, and this is June 21. So what we see is extended duration of action or continued action with brolucizumab. So the right eye is stable. The left eye, the vision is not too great, but he reports significant improvement in the scotoma, which he normally had with aflibercept or ranibizumab. So coming to the study, we included both treatment naive and switch therapy eyes. The most common type of macular neovascularization was type 1, and the most common type of fluid localization was intraretinal. So in the treatment naive group, a mean of 2.1 injections were required after the 3 mandatory loading dose injections. 15 out of 25 patients showed a 15-letter gain. 56% had a type 1 macular neovascularization, and 17 out of 25 eyes had recurrent exudation at some point in time during the 10-month follow-up. 16 out of 25 eyes had a final visual acuity of 20/30 or better. In the switch therapy group, the most common indication for switch to brolucizumab was frequent injections, that is, inability to extend the treatment interval beyond 4 weeks. So the mean number of brolucizumab injections in this group was 4.2. About 10% eyes gained 15 letters or more, and 9 out of 80 eyes had a final CDB of 20/30 or better. Now, in terms of letter gain, we started off with a lower baseline visual acuity, and that probably accounts for the higher visual gain that we have reported, because there is this so-called ceiling effect. So this was perhaps not applicable to our patients because we started off with a baseline visual acuity of 49 and 40 letters. In the treatment naive group, 19 out of 25 eyes showed a dry macula after the loading phase. In the switch therapy group, a mean of 1.8 injections were required to achieve a dry macula after initiation of brolucizumab therapy. 13 out of 25 eyes in the treatment naive group completed the first Q12 successfully, and eventually 16 eyes could be prolonged to that. In the switch therapy group, 25 eyes initially, and eventually 34 eyes were extended to Q12. Now, this is another study that we had come out with, and the reason for initiating the study was that one of the purported causes of intraocular inflammation is frequent injections, not unlike what we saw with the Merlin study. So what we did in this study is, it's a small study, just 27 eyes, but with a reasonable follow-up of about 8 to 11 months. So what we saw in this study, what we did in this study is initiate PRN therapy from baseline, not unlike what we do in India anyway. In this study, if second or consecutive injections were required, they were to be injected every 8 weeks instead of the biblical 4 weeks. So what we saw in this is that about a quarter of the eyes showed complete resolution of exudation with 1 injection, and nearly 50% eyes showed complete resolution with 2 injections. That is administered, of course, 8 weeks apart. 4 eyes out of 27 did not have recurrence until the end of the follow-up period, which was about 10 months. So they just did well with 1 injection. And this is a representative case. As you can see, the multi-layering has disappeared. I mean, almost disappeared, and complete resolution of fluid as well as complete resolution of symptoms. So this was the visual acuity graph. We can see it's not unlike what we see with most cases of AMD. Initial great response in terms of letters, and then a slight decline, and then a stabilization. Now, this this particular publication that we got out about, I think, a year ago, has nothing to do with brolucizumab. But what it tells us is that there is a definite subset of patients that do very well with 1 injection over extended periods of time. This has been observed. I'm sure everybody has seen this with aflibercept or ranibizumab. Now, the whole point of creating brolucizumab was to reduce the frequency of injections. Now, to me, or I'm sure to everyone here, it is counterintuitive to create a molecule that lasts for 3 weeks or 3 months and then inject it every month. It's like injecting the dexamethasone implant every month and then complaining about IOP rise. So that is probably one of the reasons. We are not yet clear about the intraocular inflammations, although there are many theories, the female preponderance, multiple injections, bilateral brolucizumab injections, and so on and so forth. So we are not yet clear, but one definite reason, as we were just discussing earlier, is the increased molar concentration. So during discussion, if there is time, we have not had any intraocular inflammatory episodes in India, but there are a couple of cases in Germany that I would love to discuss. But I think the best way to proceed with this molecule, and I mean, I would love everyone's opinion on that, is to start off PRN, not commit to this so-called loading dose concept, which is traditionally being used either for aflibercept or ranibizumab. They're different molecules, and I believe that every molecule deserves its own treatment protocol. So I'll just end my presentation here, sir, and thank you very much for your attention.
Thanks, Aditya. I think a lot of learning from your presentation. And the
sir, thank you.
Main learning was, I think, your reverse study, which I had read in detail. And the probe study also shows that, you see, you should have, and I have been shouting for a long time and fighting with Novartis, please do not propagate loading dose in this.
Exactly, sir.
Even though because the gut feeling was, like you very rightly said, a molecule which has been created for extended duration, why push every month? And that's the whole reason for fallout of Merlin study also, because they were injecting they were mandated by the protocol. Har month dena. So obviously, will come.
Absolutely.
So I think before we run out of time, let's hear Maiti, and then we'll have 5-10 minutes of discussion.
Okay.
There are a lot of points which we have noted. We'll come up because I don't want to miss Maiti's talk.
Thank you, sir. I will be sharing the real world experience of this new molecule. Quickly, I will go through a few of my cases. This was my first case. This was a bilateral medico himself. This was the OCT. You can see the fluid and the vision. This patient, the other eye was shrimp structure, so we didn't expect much improvement in the other eye. So we gave 1 injection of Accentrix in the left eye, and this right eye, we had given an option of aflibercept and brolucizumab. This time it was in October 2020, and this patient being a medico has chosen this new molecule. And lucky for him and us that we saw the effect quite significantly as far as the vision was concerned. I can see from 660 to it improved to 636, and you can see the lesion size also reduced quite significantly. And that time we actually was following the Hawk and Harrier the methodology. We were using the loading dose every month, and this is after the second injection, where we saw further improvement to 624, and the lesion is almost gone. And this is the third injection, and we have already completed 4 to 5 months after the loading dose, and this patient is doing pretty well. So from 660, it improved to 618 in the treatment-naive CNVM. Coming to the second case, this was a recurrent CNVM. After it responded pretty well with the aflibercept, But after 3 doses in follow-up, after 6 weeks after the third dose, there was a recurrence and the vision actually came down to 660. And then we switched to Peganex, and this is the result after the single dose. It's almost gone, and the vision was 612. As this was a recurrent CNVM case, we were not giving injection every 4 weeks. We were waiting, we were actually following up this patient, and at 12 weeks, the fluid started coming up. We get the second one. And a very similar picture happened after that. After the second dose, after 12 weeks, the fluid started coming up. And this is after the third dose of Peganex. Till now, the patient is doing well. We are almost on the verge of 3 months. And the next month, she will complete the third month. So this was a recurrent CNVM case following 3 doses of aflibercept and responded pretty well with this new molecule. Case 3 was a refractory case of CNVM. This is also a patient where we were giving monthly, not monthly, rather it was every 6 to 8 weeks we were giving aflibercept, but still the lesion was coming up after 8 weeks. So when we switched to brolizumab, it responded pretty well. The vision improved to 6/9, and this patient we had given 2 injections. So if this 3 types of patient actually, whether it was a treatment naive CNVM case, or it was a recurrent CNVM or a refractory CNVM, all responded pretty well in terms of visual acuity as well as the anatomical. As you can see, the 3 OCT is almost like a normal OCT. Now coming to our study, this brolizumab in neovascular age-related macular degeneration, the Indian real-world experience, the BRAIL study. Thanks to my co-authors. The purpose was to assess the short-term efficacy and a safety profile of this intravitreal brolizumab injection in Indian eyes with neovascular AMD under real-world scenario. It was a multicentric, retrospective, consecutive, interventional, uncontrolled, non-randomized study incorporating data from 4 tertiary care centers in India. Now we had, this is the patient characteristics and the data, 94 eyes of 94 subjects. 20 patients was treatment naive, and rest of the majority of the patients were refractory cases or recurrent cases. 74 switch therapy patients where already there was the injection was 8.63 plus minus 4.74 injections. So there was a lot of treatment with anti-VEGF, prior treatment with anti-VEGF. The parent protocol was performed in the most of the cases based on the fixed visual and tomographic criteria. The anatomical parameter was a persistent fluid that is less than 100 micron reduction of fluid or worsening of the fluid was just a retreatment criteria. And another retreatment criteria was drop of greater than 1 Snell's line visual acuity based on the PRN regimen. Now, primary outcome measures include the change in the BCVA and improvement in the central subfield thickness from baseline, along with the safety analysis. And the secondary outcome measurement were the changes in the subretinal fluid, the intraretinal fluid, and the pigment epithelial detachments. Now, coming to the results, the number of injections and followers. The patient received a total 126 injections, and 69.1% had received 1 injections only, and the 2 injections was 25.53, and more than 3 was 5.31%. The patient, this is the minority of the patient who actually received more than 1 injections. And the mean number of injections was 1.36 injections, and the mean follow-up was around 10.22 plus minus 2.1 weeks, roughly around 3 months. As far as the visual acuity, improvement in the visual acuity was concerned, it was the overall cohort showed a statistical significant improvement in the vision, both in case of the treatment naive as well as the switch therapy. This is the mean CST reduction from baseline to the final visual acuity, which also showed statistical significant improvement in treatment naive as well as the switch therapy arm. As far as the adverse event was concerned, all were minor side effects like ocular pain, burning sensation, subconjunctival hemorrhage. Only 2 of the patients had subretinal hemorrhage, which might be a natural course of the disease, and 1 patient had a RPTF, which also can be a natural course of the disease. And it was compared with the other studies, which was the number of injections. In Braille study, it was 1.36, in Reva study, it's 2.1. As far as the fluid resolution was concerned, this is a comparison with the Brew study. The number of injections in the Braille was 1.36 and the Brew was 1.4. And this graphs are showing the complete resolution of the intraretinal fluid, and the orange one is the complete resolution of the SRF, and this is the complete resolution of PED. And this is the finding in the Brew study, the fluid resolution in different compartments. To summarize, the burden of neovascular disease, as it's already been discussed, that is the main reason of treatment dropouts and resulting in the suboptimal visual gains. So this new molecule is a first of its kind of a single chain fragment variable to be used in ophthalmology. And Hawk and Harrier has actually proved the effectivity of this molecule in reducing the treatment burden among the patient of neovascular AMD as well as the PCV. And the Braille study is the first published literature of this real-world evidence of rodizumab in Indian patients. And this new molecule has provided not only superior visual gains and anatomical reduction in the patients of neovascular AMD. And it appears to be safe and tolerable in Indian patients. We have seen the Hawk and Harrier, there is 4% of incidence of the vasculitis. There was mostly the Caucasian patients. There can be some ethical predilection in as far as the side effect also goes. So, because no report of any vasculitis or a occlusive disease has been seen during our study and majority of the procedures which has been conducted in India. Thank you.
Truly wonderful, Matthew. Really impressed by this study, and this publication gives a lot of confidence, I think, to the entire Indian ophthalmologists who will, derive a lot of confidence in now using. So wonderful results you have shown, even in patients where switch therapy is there. That is another thing which I learned, that even in switch, because I was expecting that in switch the amount of visual improvement may be less because of the multiple injections or maybe scarring induced there. So let's have a short discussion. Zubi will take another 5 minutes or so. I know it will. Can we?
Okay, sir. There is no other
Yeah.
session.
So I think there's a lot of things to be discussed about. I'll just share my screen for a couple of minutes. You see, all of us have agreed that loading dose in India, like Gunjan also started this, may not be required. And Aditya said, let's have PRN from the beginning, and that probe study adds. Everybody agreed that we can have a longer duration. In fact, I was really impressed with Dr. Khatri's data that a lot of these patients, fortunately or unfortunately, we have had experience in the COVID era. So a lot of patients were lost to follow-up, and once we injected, they could still be maintained. The problem is this Hawk and Harrier. I have highlighted this red and blue here. This label here, comparative, which shows nearly 4%. This is FDA label showing vis-a-vis aflibercept 4 versus 1%. But the data, published data now, Matthew as well as Dr. Aditya, the inflammation is there, but not so much. In fact, the Braille study does not show. So I thought, let's have a compilation. I think all of us agree that duration is on our side. Aditya very nicely put, जो molecule बनाया बड़े duration के लिए तो उसको बार-बार क्यों दें? And second is there is a definite drying effect is dramatic. And in fact, normalization of contour, which everybody has shown in OCT pictures, is remarkable. And wow effect, which every presenter has said, is virtually unseen kind of thing. And visual improvement is faster and comparable. And frequency of injection, again, I think all these speakers which they have said need not be, it should be around Q10 or Q12. This is what I listed from my presentation. So the issue was about this. The lower three, I think most of us agree. Issue was, is the inflammation there? At least whatsoever we have seen, maybe Indian eyes, genetics, so many other things, or the frequency of injection, we do not give it so frequently, so it's not borne out by the data, whatever we had. The other thing is risk of vascular occlusion. The braille study by Mathi, none out of 94 eyes. Reba study out of 151, 105, only one. Then, fortunately for us, none of these eyes have been lost for any vision of this. Very important point which Gunjan also brought up and others concurred was this cost. And I just put this here, and cost was around 29.5 or 30. And if you compare the economics of anti-VEGF, this still works out to be cheaper or at par with the other anti-VEGF injections. So this data also I got just now. As of now, in India, we have more than 600 prescribers who have given more than 6,000 injections of brodocimab. And whatsoever has been reported in that, has been adverse events in around 46 of these eyes. And retinal vasculitis has been reported in 1, retinal arterial occlusion in 1, inflammation in 12 eyes, which have been managed by topical steroids. And rest of this, around 34, complain of effects like subconjunctival hemorrhage, floaters, or transient effects of haze, but no vision drop in any of these patients. And this was a couple of more studies, I thought, which there's one SHIFT study available, and this data from, Dr. Sharma from Coimbatore, where he listed, along with the, authors from abroad, there's an emerging disconnect between the trials and the real world scenario as far as brodocimab is concerned. So there's another study where more than 12,000 patients reported by Dr. IP and noticed that no inflammation in more than 97.6%. And inflammation occurred in around 2.37%, and all of them got resolved. This is another data which I had discovered. So with this, I'll stop sharing and be open to any questions or any clarification. Rajiv, are you there, or we asked for you a couple of? Yes, Gunjan, you are muted. Gunjan, you are muted.
Sir, in the south, southern India, the usage is much less as compared to northern India. I think so. But can you tell, sir, why is it so? Any specific reason?
As far as I know, the data maximum usage is the eastern part. Eastern part is the maximum. As far as I could collect data, maximum is the eastern part. Second is south. Third is west. Last is north. In fact.
Okay. So actually, one of my patient went to Shankar Netralaya, and there they told that we avoid using this because inflammation is being seen in this. So I thought.
And when was that?
Not using it.
No, Gunjan, kab ki baat hai?
Sir, maximum 1 month back.
So you see, I agree. Even RP center, believe me, the tertiary care center hasn't used it even a single injection. But that does not necessarily mean that you see the more than 1,500 retina specialists should not.
Sir, if I have permission, just can I share my screen for 1 minute?
Yeah, please.
Just an interesting case. We in the REBA study we included about 10 eyes from India, and in the probe study about 15 to 17 eyes from India. This is just out of overall in both. If you combine data from India and Germany, we have done almost 730 procedures. This was the only adverse event that we saw. Again, it had all the risk factors for. Can you see?
What were the risk factors for inflammation?
Just open this and get back, sir.
This shows CME also, yeah.
Yes. So, sir, this lady. So, I'll just. This was a lady who had already received about 70 prior injections. 70. Yes, sir. The 70 over 5 or 6 years or something, I think. Now, the indication for switch was inability to extend the treatment interval beyond 4 weeks. So 2D represents the point in time when she was shifted to brolucizumab, and 2E is 1 month after the first brolucizumab. So she received 5 consecutive monthly injections. After the 5th injection, I'll come to the perimetric scans later. From 2H until 2K, she presented with hemianopia, and she presented within 4 hours of onset of symptoms. So this angiographic sequence was done at that point in time. We see this little arterial occlusion. Now, as per the treatment protocol in Germany, she was referred to the stroke clinic, where she received low molecular weight heparin. So 2L until 2N represents the images that were taken 1 day after the heparin administration. We see complete recanalization. 2F is the pre-heparin perimetric scan, and 2G is the post-heparin. We see complete resolution of the field defect as well. So now, again, this throws up another question. If it was an occlusive vasculitis, why would heparin work? The second case, I would not attribute it to brolucizumab. It has probably more to do with vitreous dynamics. But again, 5 consecutive monthly injections in this 70-year-old gentleman who had already received 50 injections. 15 days later, in both these patients, they presented a fortnight after the 5th consecutive brolucizumab injection. We see this macular hole. We were able to successfully operate him, and his vision was restored to the pre-adverse event levels. So just some food for thought for discussion.
I think none of these macular hole. I also, in fact, one reported a long time back to ranibizumab, but I don't think that was a coincidence. I don't think so. That may have altered.
No, it has nothing to do with brolucizumab.
That may have altered the injection. You see, sometimes VMT gets precipitated or pulled off. That's okay. I don't think so. It has anything to do with the drug at all.
Absolutely, absolutely.
Yes, Dr. Chakitan, you had some questions. Now, Rajiv, you are joined.
Yes, sir. I'm very much there. I'm listening to the wonderful talks, and thanks. I think I've not used a single injection as yet.
So, the compelling data, which has been presented in this forum today, believe me, I would request Dr. Mehti as well as Aditya to now have a comparative, you see, head-on with similar to what Hockenhead did, maybe a short study and publish about the inflammation, because people are still scared about all this, and come up with publication. And Anuradha, what prevented you from summarizing that brolucizumab can be considered as a first-line agent? Because in your summary, 8 points you listed, but वहाँ पे ये नहीं लिखा कि it can be considered.
Personally, it has been my first-line choice in CNVM and PCV.
That is the reason I'm asking. You still didn't put up the slide. Well, they noted 8 points, but 9th point was missing. So, Rajiv, what is the hesitancy in your mind?
Keep on listening to all this vasculitis, intraocular inflammation from lots of people, but I guess after listening to all the talks here and coming out of your mouth and Mehti and everyone, I think I can give it a go, because so far with Eylea, the results have been fantastic. Shifting from Resumab to Eylea.
I am with you. I am also a very conservative person. We started very slowly, but today I have no hesitation. You see, today data was presented even in doctors, orthopedic surgeon, gynecologists. If Srinivas Joshi can do in orthopedic and all the gynecologists also, so I don't think so. There is, and very important. And in case Aditya and Rida have data from Indian patients published now in international literature.
You bought me today, sir.
I'm not buying. No. Rajiv, my only thing is
you bought my confidence.
I was telling Gunjan when I was in RP Center, I would love to have data from all the molecules. Then only we can say, see, we tried Macugen. I told in one of the conferences, Macugen is water. Macugen pani hai. Not because result data nahi tha mere paas. There's no improvement. I told long before that study was published, Macugen or PCD mein farak hi nahi hai. It's down only. A long time back. So you should have, you see, till the time you try, you just can't go by what you see. Therefore, we started hesitantly. Today, believe me, at least 2 of my patients, I can say, 2 of my patients beg for it. Yes, Aditya.
Sir, just to, the whole discussion has been centered around treatment eye versus switch. I think from whatever data we have, it is pointing towards a type 4 hypersensitivity reaction, whatever we are seeing. So in fact, if anything, I think the treatment naive patients are the safest to gain experience from. I mean, we have even injected monocular patients with this. they just need one injection and they're happy for 3 to 6 months. So then if they do come back, then at that point in time, perhaps, even a so-called sandwich therapy with other molecules if need be. But I think for treatment naive, we can, go full guns blazing. And then, for switch patients, perhaps, in fact, after multiple injections, it is the switch patients who probably need to be monitored closely. That is the impression
I agree. Theoretically, I am with you on this, that it is the naive which should do much better with regard to IUI.
So can I ask a question?
Yeah, Rajiv, sure.
So what are the patients, what are the OCT biomarkers we are looking at once you decide whether to give this molecule vis-a-vis some other molecule, which may be more economical for a patient? Is there any specific, it's to you and all the panel, where,
I don't think so there's any specific biomarker that this will compel you for brolucimab. But what I see is it works the best, one of the best indications for IPCV type 1 membranes, and as well as occult membranes, IPCV and PCVs, and non-responsive in any case, or large PEDs. It works miraculously well. Believe me, the normalization of contour, which all of us have shown, I have also shown, Matthew has shown, Aditya has shown, Srinivas has shown. Believe me, the normalization of contour I have never seen actually. So, वो एक wow effect है. You see wow effect 3-4 people use today. That wow effect दिख रहा है. So, considering economics which Gunjan raised, Gunjan said about economics. Economics, अगर counter भी करो आप 29,500 vis-a-vis, it works up to cheaper than the other anti-VEGFs. Duration of action again, and prolonged duration and regression again very good. So
I think we need to do the math with the patient, the mathematics. And once the patient understands the mathematics, lesser follow-up, lesser injections.
So third homework for both of you is write down about economics of anti-VEGF.
Yes.
With respect to brolucimab. Very important, very important.
I think with 6,000 injections, we can have a fantastic publication if everybody just collaborates.
That's the homework for Novartis people in case we can have this data.
Yes,
Tirumale
sir wants to.
So, reviewing what the Hawk and Harrier published, and when the ASCRS asked Novartis to form a safety review committee, they published a paper saying that why these IOIs tend to happen anywhere between 2 to 4 weeks time. No, it is usually 4 weeks to 12 weeks time.
Okay.
It is when they went on to their subsequent injections that this started happening. So if you review back and ask Novartis to give you this particular publication that they submitted after the Osprey to the FDA, they found a very important finding that 40% of the patients who were given this injection when they did the tox study had anti-brolucizumab antibodies even before the molecule was released.
Oh, good.
Yes. So the problem here is that although it is a single chain fragment that is going to go and block a receptor, okay, so this particular molecule had a problem that 40% they were autoantibodies, and this is to a certain extent related to the HLA kind of a immune mechanism that gets mounted. That is why it is predominantly seen in Caucasians, and you have not seen not convincing reports from other parts of the world. Yeah. So
this is partly strengthening what Aditya said.
Exactly. So the thing is, what probably Aditya you should do is that in the patients where there is an intraocular inflammation, you should collect the blood also, send it for an HLA reporting, because only those patients who develop an intraocular inflammation, it becomes imperative that you study them deeply. HLA matching.
You are well known for that. So I think you should
no, I'm just saying if you can pull in the data.
Yeah, absolutely.
When you get it, we will be more than happy to do it for you, because me and a fellow scientist back at Netralaya, so we discussed this at length. But the thing is, the matter boils down to compilation of sample. So when you're looking at HLA matching for these kind of patients, what you should actually do is, send the bed immediately, probably store it at 72 for quite some time, and then you have adequate number of samples, probably redo them again and kind of correlate. That's one important thing, that they don't want to get back the autoantibody data to it, because it adds a lot of fire to what has been already going on, and everybody is crazy about the intraocular inflammation. 4% is actually a scary number for people to try, but the Indian experience, I think, kind of changed a lot of things, because we are a little different HLA wise than the Caucasians and the other.
Absolutely, I agree. Yes, Dr. Chakitan, you had some question.
Yes, sir. I think it's a wonderful molecule, sir. I have also gained more confidence today. But my humble submission was that, everybody has access to all the information these days.
Yes.
One case is enough to ruin your career. You have one intraocular arterial occlusion in a one-eyed patient, and they go to court, they pull up the articles. Lawyers are very smart. They will come up with that international studies which have more weightage. They would say the number of patients was more. So my question was that if we do an Indian study, that would be great with more number of patients, and VRSI can come up with some kind of guidelines that this particular molecule is safe. So, we are more covered. In case
Absolutely, I agree, Chakitan. In fact, one of the webinars I did point out to Dr. Raja Narayan that VRSI has to come with statement. But I'm happy now that you see we have two publications which have come out from India and by Mehti and Aditya. This will add confidence for everybody.
Absolutely.
You see, then only VRSI, everybody depends on data. So, like Aditya was saying, if we can have data of this 6,000, nothing like it. That gives confidence for us to move ahead.
I think, sir, Dr. Raja has initiated the survey on the brolucizumab, and it had corrected the data on the side effects as well, adverse effects as well.
So, Chakitan, we are at it.
So practice patterns combined with real data, I think that would be the best combination. Like practice patterns you have already collected from VRSL side. So, perhaps it's combined data, patient data. That would be fantastic. Yes.
So I think we had very nice discussion. We should thank DOS for giving us platform. And I'm really thankful to Apoorv for initiating this. And then Srinivas, Manoj, Aditya, Andrit.
Thank you, sir.
And very happy that Gunjan and Rajiv and Tirumulesh and could participate. Pavan, we had very nice discussion. And what maybe I can summarize in one or two lines is these two publications have given us a lot of confidence. And Gunjan, very happy that you pointed out towards economics. And I had this in my mind that somebody should publish a paper on this also, economics of anti-VEGF injection. I have myself published in American Academy also. 40% reduction, I think the cost is definitely there, but we can, list down. There are 10 parameters which I had listed down, like travel cost, stay cost, relative cost, OCT cost, consultation cost. So many variables are there. And if the duration of action, the beauty, like Aditya pointed out, if the duration is prolonged, then why give every month? And the other learning has been, do not, as of today, inject every month.
Yes.
Are you there? That every month we should not advocate. Or you still want loading dose?
Initially, I had used loading dose, but nowadays I don't give before 8
Yeah. So duration is in our favor. The cost is in our favor. And then wow effect, which I learned for the first time in ARMD, wow effect bhi hota hai ARMD. So that is very good. Anybody else would like to add? I think with this we should thank Novartis as well as DOS for allowing us extra time also. And thank all the speakers for wonderful slides by Manoj, Srinivas, Amrita and Aditya. And thanks Aditya for showing those last two very good information of yours.
Thank you, sir. Thank you very much, sir. Thank you.
So, thank you.
Thank you so much,
Thank
everybody.
you so much.
Thank you, everyone. Good
Thank
night.
you, sir.
Thank you.
Sir, a
Night.
virtual round of applause for everyone.
Thank you
Thank
so
you.
much.
Thank you. Bye bye. Good night.
Thank you, Zubi, for sitting with us.
Thank you.
Thank you, sir.
Okay.
Bye. Bye.
Thank you,
Bye,
sir.
sir.
Good night.
See you
Bye.
next sometime.
Bye,
Yeah,
Dr.
bye bye.
Yeah, bye.
Bye, Aditya. Bye, Tirumulesh.
Bye, sir. Bye. Bye.
Bye, Aditya.
Bye.
It's not leaving.
Rupesh, see you tomorrow then.
हेलो
See you tomorrow then. हो गया ना आज का?
हाँ हाँ
Okay.
ओके ओके